I'm Mamta Parikh. I'm with UC Davis Comprehensive Cancer Center, and I am asked about practice-changing updates from ASCO GU 2023. There were not actually any practice-changing updates based on new therapy data that were presented, but there were important data that help inform our treatment decisions. So I'll start with metastatic castration-sensitive prostate cancer, and in particular we'll focus on the ASCO trial. This trial looked at patients that were castration-sensitive, had metastatic disease, and in the opinion of the investigator were eligible for docetaxel. And these patients were randomized to receive darolutamide plus docetaxel for 6 cycles plus androgen deprivation therapy, or placebo plus docetaxel for 6 cycles plus androgen deprivation therapy. The primary endpoint of the study was overall survival and had previously been reported to be superior with darolutamide compared to placebo. But at ASCO GU 2023, Dr. Hussain presented an update that looked at stratification of patients, which I think is really important. And so looking at the patient population in these studies, about 70 to 75% of patients had either high risk or high volume disease as defined by either the Latitude or Charted studies. And by the ASCO study's own definition, patients did primarily have bone metastases, either with or without lymph nodes, and about 18% of patients had visceral metastases as well. So in patients that had high volume disease, there was still clearly a benefit to the combination of darolutamide and docetaxel and ADT compared to placebo plus docetaxel plus ADT. In low-risk patients, this was not statistically significant. And in high-volume and low-volume patients, there seemed to be a benefit of the triplet. This is important because when we select patients for who we want to give triplet intensification therapy to, it is important to know who the patients were that were enrolled in the study, and it does seem like patients that have high volume disease in particular should be thought about for triplet intensification therapy. In the castration-resistant setting, we saw updated data regarding rucaparib, a PARP inhibitor, and that was based on the Triton-3 study. This study looked at patients receiving either rucaparib or physician's choice of either an androgen receptor pathway inhibitor or docetaxel. And these patients had to have either a BRCA or ATM mutation. Most of the patients on the study did have a BRCA mutation. The study did meet its primary endpoint of radiographic progression-free survival benefit, with patients that had BRCA mutations in particular benefiting the most. ATM patients did not seem to benefit as much, and this is reflective of data that we've seen with other PARP inhibitors as well. But it's important to note that there were very few patients on the study that had ATM mutations. There were also studies that showed the combination of PARP inhibitors plus an androgen receptor pathway inhibitor in patients that were unselected in terms of homologous recombination repair mutations. These were the PROPEL study as well as the TALA-PRO2 study. So these studies looked at the combination of abiraterone and prednisone and olaparib in the case of PROPEL, and talazoparib and enzalutamide in the case of TALA-PRO. Both of these studies showed a progression-free survival benefit in the unselected patient population, and the combination of abiraterone plus olaparib is currently under FDA review for approval in the unselected patient population. Interestingly, in the PROPEL study, patients with homologous recombination repair mutations did seem to benefit more than the patients that did not, and so this will be an important part of thinking through how we treat. The other aspect that does complicate things is that in both studies, very few patients had received any kind of intensification therapy in the castration-sensitive setting. And so we do wonder where we will actually fit in the combination of an androgen receptor pathway inhibitor and a PARP inhibitor. I'll turn my attention now to bladder cancer. There were 2 updates that are important to note. The Keynote 057 study reported data from cohort B, which looked at patients that had non-muscle invasive bladder cancer with a papillary urothelial component, but without carcinoma in situ. And these patients had a 12-month disease-free survival rate of about 88%. And that is quite a good response, although this was a single-arm trial just like cohort A was. The FDA currently still indicates that pembrolizumab should be used for patients with CIS features. There are not data, the data for cohort B have not yet been reviewed by the FDA. In the adjuvant space for patients with muscle-invasive bladder cancer who have undergone cystectomy, we know that the CheckMate 274 study has shown a benefit to adjuvant nivolumab for these patients. They received nivolumab for 1 year, and there was benefit in progression-free survival compared to placebo. And there was updated data that was presented by Dr. Galsky that showed that these trends continue to persist. There's a clear benefit in progression-free survival to treatment with nivolumab. The important components to keep in mind with CheckMate 274 that hold up even with follow-up are that there are very few patients on the study that have upper tract disease, and the patients that seem to benefit the most had received neoadjuvant chemotherapy. So we must keep this in mind when we consider nivolumab for adjuvant therapy for patients. The other important thing to note that was not presented at ASCO GU but is really important in our practice is that on April 3rd, the FDA approved the combination of enfortumab vedotin plus pembrolizumab. This was based on single-arm studies, but with very impressive objective response rates and durations of response. So this is for patients with metastatic urothelial cancer that's cisplatin ineligible and has been untreated and will undoubtedly change the landscape of how we treat metastatic urothelial cancer. I'll switch gears to renal cell carcinoma. And again, no new trials that were presented, but an important update was presented by Dr. Chueri on the CheckMate 9ER study. This study looked at cabozantinib plus nivolumab versus sunitinib in patients with metastatic RCC, regardless of IMDC risk group. And the primary endpoint for this study was progression-free survival. This study had already been reported to show benefit in progression-free survival in the combination of nivolumab plus cabozantinib, and this progression-free survival did persist in long-term follow-up. Patients are living longer and longer with metastatic renal cell carcinoma. In this study, the overall survival benefit was quite marked with the combination of nivolumab and cabozantinib, and patients living nearly 4 years with treatment. So we're seeing a lot of advances in metastatic RCC, and there's a lot more to come. And I think currently treatment of genitourinary malignancies is a very exciting time to be investigating therapies. Thank you.